So we'll call upon Dr. Amit Porwal since he has to leave for another session. He'll talk on Bleb needling, an effective procedure for saving a failing Bleb.
Thank you, Team UKSS. So my video is on Bleb needling, an effective procedure for saving a failing Bleb.
I have no financial disclosures to disclose. Goal of needling is to re-establish the fistula between the anterior chamber and the subconjunctival bleb, where aqueous humor can be reabsorbed. It was first described by Ferrer et al. In 1941, and bleb needling with mitomycin was described by Madeli et al. In 1996. So coming to the failing bleb, this is an encapsulated high dome appearance of bleb. This is a failing bleb, which is it can be an early failure or can be a late failure. Early failure is within 1 month, and late failure is after 1 month. This is a failing bleb which is flat, which has highly vascular. It has very large number of corkscrew vessels. So this is another sign of a failing bleb. Now coming to the procedure of bleb needling. This is a very important procedure. You have to understand it properly. This procedure can be done in the OPD or the OT. I am doing this procedure in the OT under topical anesthesia. So an 80 corner stay suture is taken. 0.1 milligram or 0.02 milligram per ml of mitomycin is injected as much posteriorly as possible into the subconjunctival space away from the bleb. After 2 minutes, waiting for 2 minutes, I'm ironing out the conjunctival tissue so that whatever mitomycin which has come anteriorly is brushed out or ironed out behind. Now with the 26 gauge needle, which is bent in the form of an L shape, I invade in the subconjunctival space away from the bleb, from the lateral margin of the bleb, about 5 millimeters away from the lateral margin of the bleb. And with the to and fro motion, I'm trying to avoid all the major vessels, the highly dilated vessels, and trying to do the subconjunctival dissection. So when you're doing this subconjunctival dissection, you have to make sure that you go as much posteriorly as possible, also anteriorly, and also to the other side of the bleb, that is the medial side of the bleb. You can starting from the lateral side. So you can feel the resistance of the subcentral tissue when you're cutting, and you can see in this that I entered the anterior chamber through the internal ostium, and as I enter the anterior chamber through the internal ostium, you can see that the bleb is being formed. So this is very important, and when you are making this position, make sure that you cut all these fibrous subtleties which are present so that the fibrosis is decreased. Then the AC is formed by making a side port incision with the help of an MBR, and AC wash is done to check the patency of the fistula and the formation of the bleb. Once this patency is checked, then you can see now that the bleb is being formed nicely, the stay suture is taken out, and then we are doing the stromal hydration of the side port wound. So this is very important to check, and this is how you're going to do the bleb needling. This is the photograph which was the same patient wherein the pre-operative, the pre-bleb, the photograph is seen. It is not multicystic, it's a flat bleb. So at 1 week follow-up, you can see a nice diffuse bleb with lot of cysts in the anterior segment OCT of the bleb. Then this last picture, which is of at 6 months follow-up, you can see a nice diffuse bleb. Coming to the bleb needling in the OPD procedure, I told you that it can be done both in the OPD as well as in the OT. It is a very debatable issue, but this is a small video which I am showing how the bleb needling is done in the OPD. So in this case, I have taken the needle is bent in the not bent, and I have entered the subconjunctival space 5 millimeters away from the lateral margin of the bleb. And this procedure is done under topical anesthesia. Patient cooperation is required. You have to retract the upper lid, tell the patient to look down, and with the to and fro motion try to cut all these septates. You can go into the subscleral flap also and try to elevate the flap, but this with this I didn't enter the anterior chamber, and you can see post needling 1 month. This is the picture. It's a nice diffuse bleb. So bleb needling can be done both in the OPD and OT. You should always give a trial of this. Post needling, what you are going to do, you have to look for the change in the appearance of the bleb. You have to give antibiotic steroid eye drops for about a month. Digital massage has to be instituted once the needling has been done so that the patency is maintained. Needling can be accompanied with subconjunctival injection of mitomycin of 5-FU combined with 0.1 ml of protein. It can be given in the superior temporal quadrant before needling, and then massage for 2 to 5 minutes of waiting period. Blood with thick scar and quick failure, you can use mitomycin, and while those that succeeded larger, longer, and failed slowly may respond adequately to 5-fluorouracil. Coming to the another procedure, I'm showing you this needling is performed in the OT. You have to be very careful when you're performing this needling procedure. Any procedure which you perform can't come without any complication. So you have to try to avoid those complications, but because of complication you can't stop doing the procedure. So when they are doing this bleb needling, you can see the large number of blood has entered into the anterior chamber. So this can be cleared off by making a side port incision and by washing out. So when you wash the anterior chamber, you will see the patency of the bleb as well. And the other complications can be the intra-bleb bleed. You can have endophthalmitis. You can have subconjunctival perforations. So these are the few of the complications which can occur in the bleb needling procedure. So how effective is bleb needling? It is more effective. It is performed within 4 months from the time of trabeculotomy. It is less effective if the pre-needling IOP is greater than 30 millimeters of mercury, or immediate post-needling IOP is greater than 10 millimeters of mercury, and if trabeculotomy is performed without mitomycin C. So this is the way the effectiveness of the bleb needling, which has been documented in various studies. Now, coming to the key points of needling, factors such as the time period after the initial trabeculotomy and the degree of scarring will greatly affect the outcome. There is a varying success rate ranging from 30 to 94% with good long-term control. It is a repeatable procedure with minimal risk in the management of glaucoma patients. So I tried needling in all my patients before I take them for a retrap or for a wall surgery. Coming to the other benefits, it avoids the risk of invasive surgery as well as the need for daily medications. Needling a previously viable bleb conserves the conjunctiva and allows faster recovery and fewer complications than repeat trabeculotomy, often with similar results. So always try to retrieve the old trabeculotomy site with needling. Always one should give a trial of the bleb needling before going for a resurgery. So the key to successful post-operative management comes with early recognition of the failing bleb. Look for the signs of the failing bleb. Correct selection and timing of the various interventional procedures which are available should be taken into account. Thank you for your patient watching.
So this is what I wanted to show about the bleb needling procedure.
Very nice. I've seen this. I think it showed in one of the OPLs.
Yeah.
Very nice. You've been doing this regularly. The first case you injected mitomycin.
So every bleb needling, we should first inject mitomycin.
Leave it like that.
Leave it. So inject as much posteriorly as possible. After you inject, wait for about 3 to 5 minutes for the whole mitomycin to get absorbed properly, and then start the procedure. So the holding
So
period.
you can leave the mitomycin there.
Yeah, it will get absorbed by the lymphotics. It will get washed away. So
normally the teaching is to wash
so
away all the
the earlier
mitomycin.
thought was when we used to use the sponge, we used to apply the mitomycin sponge and we used to wash it thoroughly so that we don't have scleral melting.
Yeah.
But there are a lot of studies now, even when you're doing a trap surgery, you give subconjunctival mitomycin, inject it, have a waiting period of 2 to 3 minutes, how much you want to have the effect of the mitomycin, and start the procedure. The mitomycin gets absorbed and it doesn't cause any damage. So
No scleral melt.
no scleral thinning, nothing.
No
Established literature is there
no
for this.
conjunctival.
Nothing. You don't have to wash the mitomycin. The wax sponge, the problem is you don't know how much concentration is being delivered because you have put the wax sponge. Then somebody might pour a fluid on it, so the mitomycin will get diluted. If there is any bleeding and all which is occurring, so again the concentration of mitomycin will get diluted. So the injections work better than the sponges.
What is the concentration of mitomycin that
So-
you are using in needling?
In needling, I am using 0.02 per 0.1 milligram, 0.02 milligram per 0.1 ml. So basically 0.2 milligram in 1 ml, so I take 0.1 ml of that. But if it's a very angry looking bleb, then I increase the dose to 0.04.
Okay. Now, since the use of more and more of mitomycin C with trap nowadays versus the earlier uses, do you think the need for needling is reduced in recent
No,
times?
so the reason for the need for reduction in needling is not only mitomycin but also the releasable sutures. So now we all do our traps with releasable suture along with mitomycin. So with these two techniques, the failure rate have decreased a lot. But then earlier thought was if the bleb is failed, then you will go for a retrap or a tube implant. But what is advocated is don't go for a tube implant, try bleb needling first. If the bleb needling is not effective, then you can go for another surgery. So bleb needling should be tried because it is not a major surgery.
So, do you prefer to doing it in OT or in OPD? Like you've shown both.
Yeah, I've shown both. So again, it depends. It's a very debatable topic because everybody prefers it to do in the OT, and I also would suggest in the OT because in the OPD it can be done provided you should know what is your OPD type. Because I'm a glaucoma specialist, my OPD is sterile. But if it's a general OPD where every infective patient also is going to be seen on the patient, on the slit lamp, then I wouldn't recommend that doing in the OPD. And the patient cooperation is very, very important.
I think it's better to do it in the OP. It's like giving an anti-VEGF in the
Yeah, so do it in the OT. That is more.
It's like that only.
And last thing,
So I don't think it's a good idea.
how do you manage the bleeding part? If if the bleeding
Yeah, so I
happens
showed you one video wherein if at all you traumatize the vessel, there will be bleeding and this blood can go into the internal washroom into the anterior chamber. You just hydrate it. I mean, continuous irrigation and the blood will, because the hydration pressure which is created, there will be natural hemostasis and bleeding will get arrested.
Thank you.
Thank you.
Thank you.